I'm Rick Donlin. I'm a combined medicine pediatrics doctor in Memphis, Tennessee. After finishing residency in 1995, three of my medical school classmates and I opened a nonprofit Christian health center in the most medically underserved part of our city. For most of the last 25 years, I've lived and worked in communities of low-income people and have delivered healthcare in those settings. I'd like to talk to you today about domestic missions, or what some people call home missions. This short video is going to be divided into three parts. First, we're going to look at the biblical and historical basis for domestic or home missions. Secondly, we're going to look at the status of health equity or fairness in the United States. And lastly, we're going to look at an example of what some Christian people in Buffalo, New York are doing to address the healthcare needs in their community.
Most of us, when we think of medical missions, we think about something that's happening thousands of miles away. But from the beginning of the Christian movement, even in the ministry of Jesus, missions was local. Jesus moved about the Sea of Galilee and Judea and Jerusalem. He restored sight to the blind and hearing to the deaf. He touched and healed lepers. As the Gospel of Matthew says, he went through all the towns and villages, teaching in their synagogues, proclaiming the good news of the kingdom and healing every disease and sickness. The disciples of Jesus after his resurrection followed the same pattern. Following Pentecost, we can read in the book of Acts and hear through church history of how Christian people cared for the neediest. They picked up abandoned babies. They helped the dying and the sickest, especially the poor. And even though the Christian church underwent a series of persecutions for the first 300 years of its life under Roman rule, it was largely Christians' care for the needy that persuaded many people to convert from paganism and atheism to Christianity. The Emperor Julian, who was the last pagan emperor, followed Constantine, who was a convert to Christianity. Julian wanted to return Rome to the pagan gods and away from Christianity, but he was unable to do that. And part of the reason, as he himself said, was because of the Christians' care for the poor. This is his quote: "It is the Christians' benevolence to strangers, their care for the graves of the dead, that have done most to increase atheism." For him, atheism was unbelief in the pagan gods. "The impious Galileans," as he called Christians, "support not only their own poor, but ours as well." Same pattern continues through the Middle Ages. Innovation in Byzantine Christianity created hospitals, monasteries, other places, colonies of people who committed themselves to caring for the neediest in their own local situations, especially in hard times like the time of the bubonic plague or the Black Death in the 14th century. It was Christian disciples who cared for the dead and dying, and sometimes faced death themselves. Similarly, in America in the 19th century, during the yellow fever epidemics, and in other cases, Christians, both Protestants and Catholics alike, in my city of Memphis, stayed during the yellow fever epidemics and cared for people, even as the fatality and mortality rates were exceedingly high.
Medical missions began as local missions, whether it was around the Sea of Galilee, in the monasteries of Europe, or in the westward expansion of the United States. Disciples have always seen the needs of their neighbors and addressed them. In so doing, they've glorified God and they've expanded the kingdom of Christ throughout the world. They've literally changed the course of history. Suffering and death are not evenly distributed in the United States. Some populations face much higher burdens of disease, suffering, and even premature death. We call these health disparities.
Lots of factors contribute to cause health disparities, including issues of economics and culture, history, but without question, a large part of the disparities in health relate to things that medical professionals have a voice in, and that's access and affordability of care. In fact, many of our neighbors, unfortunately, have difficulty securing health care because access is too expensive. Specifically, studies have shown that ethnic minorities often forego care because of the lack of availability or affordability of care. This occurs in all ethnic minorities in the United States. This is a map of my city, Memphis, done by a demographer named Eric Fisher. Eric Fisher studies race, and in his maps, every dot's 25 people. In this map, each blue dot represents 25 black people, red dots represent 25 white people, yellow dots represent Latino people. In the case of Memphis and in every major city from coast to coast, there are separations of people in urban centers by race. And in Memphis and in every other major city in the United States, there is a dramatic breakdown in health disparities across racial barriers. In my city and in most cities, there actually are enough resources, physicians, dentists, and other health professionals to meet the needs of the entire population. But the vast majority of resources are located in areas where you see red dots, where there are people with more resources. So we've said for years, and it's true across the country, in places where you see concentrations of red dots, doctors typically compete with doctors to get patients. But in areas where you see blue or yellow dots, patients compete with patients hoping to find doctors. The healthcare system is kind of complicated in the United States, but not that hard to understand. About half of Americans receive health insurance that is paid for in part or in all by their employers. That's so-called private insurance. Another 14% of Americans are covered by Medicare, which is government-provided health insurance for the elderly and disabled. Most people who participate in the Medicare system have paid into it through their jobs over the years. About 9% or more of Americans have no health insurance at all. And about 20% of Americans rely on Medicaid, which is also government-provided health insurance, in this case for the poor. There are significant differences in how Medicaid is administered across the United States because it's jointly run by the federal government in each individual state. So there are some states where Medicaid provides fairly generous benefits, especially for women and children. But there are also many states, particularly in conservative parts of the country, where Medicaid benefits are smaller and they're restricted to even smaller portions of the population. There are many places in the United States where physicians, dentists, and other healthcare professionals are unwilling to participate in the Medicaid system because they believe that the payments are too low. So overall, it's important to understand that almost a third of our neighbors in the entire country, probably north of 100 million people, either have no health insurance or have poor paying health insurance like Medicaid. Who gets sick? Well, of course, everyone gets sick, but one of the points of health disparities is that diseases occur earlier with more power and more harm and cause death sooner in ethnic minorities. This is just an example using diabetes, where you see that the rates of diabetes are significantly higher in non-white racial groups. Again, these are the groups that typically live in areas where health resources are limited. If we look specifically at African Americans, which is the patient population I've been involved with through my career, almost every possible health condition, high blood pressure, heart disease, strokes, kidney disease, diabetes, HIV, nearly every sort of cancer is more likely to affect African Americans, more likely to affect them earlier, and unfortunately more likely to have them die at an earlier age than similar people from the white race. Specifically in my county, in Memphis, a white male born in 1964 is likely to live about 8 years longer than a black male born in that same year.
Health disparities are real. They exist in cities and in rural areas. Low-income people, especially ethnic minorities, suffer with disease and the consequences of disease, even death, at much higher rates than the majority population. This is an opportunity for Christian disciples. I asked my good friend Steve Noblet, who is the executive director of the Christian Community Health Fellowship, to sit down with me and talk about some of the ways that Christian people across the United States are addressing healthcare needs and working for a more equitable system.
For over 40 years now, there's been a growing community of Christian health professionals that are trying to address the issue of health disparities as part of the gospel. And they're doing it by using healthcare here in the United States, both as a demonstration of the kingdom of God and a platform to proclaim it. There's a whole lot of examples of those around. The community's grown to over 300 clinics across the country, all working in medically underserved areas with populations that are mostly neglected populations in our country. A lot of them are seeing more and more how domestic missions is really a part of God's global missions and how international missions and domestic missions are tied. One great example of this is a clinic up in Buffalo, New York called Jericho Road Community Health Center. Dr. Myron Glick had been raised a missionary kid in Central America and felt God's call on him to become a doctor. And he opened a private practice and wanted to care for the poor. And it's very difficult to do that in a private practice in a city. And he struggled and struggled until 9/11. But when 9/11 happened, the state of New York began to shift where they resettled refugees from New York City to Buffalo. Myron was one of the few doctors who was willing to open his doors to those people and begin to see them. As he began caring for those refugees and hearing their stories and seeing their situation, he realized that there was greater needs that they could step into. Jericho Road started a resettlement agency to pick up the needs and really train people how to do banking, how to live here in the U.S., how to begin to care for themselves and become established as communities. Through all of that, many of the refugees were coming to Christ, and they began incubating church plants. There's a church plant of sub-Saharan Africans. There's a church plant of Burmese and a church plant of Nepalese people that have sprung up through the help of Jericho Road Community Health Center.
In conclusion, medical missions didn't begin as international missions but domestic, and has existed in every phase of the church where Christian people look around their own culture, their own world, and passionately go after serve and compassionately serve their neighbors' needs. Secondly, the existing healthcare system in the United States is far from equitable. There are really unforgivable disparities in health in the way people suffer disease. And part of that, not all of it, but part of it has to do with access and the cost of healthcare services. This is a real opportunity for Christian disciples to show the kingdom of Jesus breaking forth even in the healthcare world and in our country. Lastly, there are many examples across the country of how disciples have taken their education and their training, and then with ingenuity and hard work have learned ways to serve their neighbors and to work hard against health disparities. Again, in doing this, disciples make God look great, and they expand the justice and righteousness of Jesus' kingdom in our world today. Won't you think about the possibility of domestic healthcare missions?